Good morning. Welcome to the Wilson Center. We're impressed that you managed the metro and the other issues getting into this building. And we're delighted to host, or maybe terrified to host a national conversation on Zika in the U.S. Can we manage the risk? I'm Jane Harmon, President and CEO of the Wilson Center, recovering politician, and think that this subject could not be more important. Over the weekend in the Washington Post, there was an op-ed by Ron Klain, whom many of us know from various roles in government, including as President Obama's former Ebola czar. He has a message for this town, quote, "Zika isn't coming to the United States, it's already here," unquote. Puerto Rico is already facing a crisis, and when mosquito season picks up, which could be any minute, the rest of the country will too. Zika is an urgent threat to American public health, but you wouldn't know it from the attitude of my former employer, Susan's too, the United States Congress. For too many members, this is just another occasion for the blame game. With failures like Flint, Michigan on everyone's mind, I'd have thought there'd be a rush to get ahead of the next preventable tragedy. Because when these public health crises blow up, politicians who drag their heels get embarrassed. But much more important, people become ill and some die. To their credit, the individuals on today's panel have been out there on the airwaves, getting the word out from a range of angles, and I'm delighted that they are taking our stage today. Susan Molinari, as I mentioned, was one of my colleagues in the House.
A reforming also.
A reforming politician also. And she, like I, has escaped the toxic partisanship. She now heads public policy at Google, which has dedicated funds, data, and engineers to mapping the transition of the Zika virus. Thank you, Google. Like me, I'm sure she's frustrated that our former colleagues aren't moving faster to address such an urgent health crisis.
Absolutely.
Rear Admiral Ann Schuchat, Principal Deputy Director at the CDC, has been combating disease for decades. And I remember dealing with you when I was in the Congress. Diseases like H1N1 and SARS, Ebola, and now Zika. For those who missed the memo, she recently suggested we could see hundreds of thousands of Zika cases in Puerto Rico and hundreds of cases of microcephaly. Let's just focus on that for a moment. My sixth grandchild, a very healthy boy, was born 3 weeks ago. And as a grandmother and as a parent, I can't imagine what it must be like to have a child born with microcephaly. We really have to do more to get ahead of this. When Ann says Zika is scarier than we thought, she speaks from a deep medical background and a long record of service. The same goes for my friend, Dr. Anthony Fauci, the longtime director of the National Institute of Allergy and Infectious Diseases at NIH. Tony's a giant in the field. So I can't tell you how nervous I was to hear him say, quote, "We can't pretend to know everything we need to know about Zika," end quote. We're grateful, again, to Jason Beaubien, NPR's Global Health and Development Correspondent, for moderating such an important conversation. We hope it can be a wake-up call for this town, especially for those folks 1 mile away on Capitol Hill. The Senate and House have passed different Zika funding packages. They actually have done something. But now they have to hold a conference to bridge the gap between the two measures. I really can't imagine that Congress is so busy that it can't find time for this priority. And I don't know when they'll conference, but tonight wouldn't be soon enough. In the meantime, please join me in welcoming our distinguished panel.
Well, thank you all for coming today. Really hoping this is going to be a conversation amongst all of us, and we will get to Q&A at the end. So if you've got some questions, think about it. We'll pass the microphone around and try to get to some of the questions you guys have too. Susan, I'm going to start with you, just on the amount of interest. You guys are, to some degree, gauging that by what you're seeing in terms of traffic, number of people who are searching about Zika in the U.S. And I looked at some of the data that you guys are pulling together, and what are you seeing? It seems like you're seeing a lot of concern out there.
That's for sure. So first of all, I want to thank the Wilson Center and my dear friend Jane for bringing me together with all of you to discuss this issue. And anytime I get an opportunity to even be in the orbit of Dr. Fauci, I feel extremely blessed. So thank you for giving me this opportunity. So Google, if I could just backtrack a little bit so I can put some of this in context, has decided about a little over a year ago to work to try and get our arms around Zika. Now, this initially started not in the United States because so much of the attention when we began this project and our partnership with the CDC and NIH was when we were focused on other parts of the world, particularly in some places where we have very large employee base, like Brazil, for example. So what Google did at this point is we have three main components of our global, and I just very quickly, product integration on search and awareness campaigns. So what we do on that is working with groups like UNICEF, we try and predict, and we do this for over 900 health conditions. People go directly on search, and now we're trying to provide more information in over 17 languages on what Zika is, how to detect it, symptoms, how to deal with it, how to prevent it, an overview of the virus, and a public health alert that we keep updating from the World Health Organization. So we do that on search. On YouTube, we've partnered with content creators across Latin America, including Sesame Street and a Brazilian physician, to try and get the word out there, to raise awareness via all their channels and their subscribers, to provide information on prevention message and for controlling the spread of mosquitoes, content in both Spanish and Portuguese. And then the last thing, which we have done for a very long time with CDC and NIH, is we've mapped global interest on the Zika virus starting in October 2015, highlighting the timeline from when Zika became a global epidemic. So with all that, plus we've given over $1 million, and we can talk about that, engineers. I can get deeper into what we're doing on the day-to-day. But to answer your question then, knowing that that's the kind of information that we look to compile, right? Because that's what Google does. We try and order the world's information. And so the concern around Zika now is really clear, and we've seen as of March, since November, a 3,000% increase in searches. And so a lot of times Google searches are very predictive of what's going to happen. I think both of my partners on stage will tell you that we work with them on flu trends. When people start to search antihistamines, or I guess that would be allergy trends, but how to cure a sore throat, how to deal with a high fever. We can sort of help the government figure out when flu trends are coming. Our guys will tell you that they could start to see the beginning of a housing crisis because people started to see this amazing burst on the scene of people trying to figure out how to get second mortgages, how to deal with bankruptcies. And so now we started to see this amazing growth, 3,000% just from November to March in terms of people searching. So that really is a dramatic increase. And I dare say, although I'd love to say it's just out of pure curiosity, I dare say that most of this comes from real intense concern.
And I think that's what the big issue is, that people are concerned. And I would like to send it over to you. How prepared is the U.S. to deal with this? We're going into the summer season when mosquitoes are about, both to manage the disease itself and that concern that people have.
Yeah, well, I need to say we're not starting at a good place. We used to have a lot stronger mosquito control and mosquito awareness, really the surveillance for where the mosquitoes are and the resistance patterns that they have. So we're really have a patchwork nation around mosquito capacity. The state health departments, the local governments are really concerned and are working on this, but we absolutely need resources to get ahead of it. This is the season when the mosquitoes are coming, and so we really have worked out plans of how to be ready and what to do at each step of the way, but we really need to build that up. We have prepared the labs across the country. CDC developed some new lab tests, has shipped them out to the states and cities and a number of other countries around the world. But those are new lab tests that don't work as well as we would like, and so we also need to get better diagnostic tests developed that will answer more questions
And
than what we have.
right at the beginning of this, there wasn't really a definitive test for Zika, was there? I mean, everything was getting sent all the way to your lab in Atlanta. Is that correct?
That's right. I mean, the CDC developed lab tests based on the 2007 YAP outbreak of Zika before we knew that it was related to birth defects. But you know, the virus itself can cause no symptoms in 4 out of 5 people, and one person will have symptoms that are relatively mild: fever, joint pain, red eyes, really a rash that's kind of itchy, but not very specific. So you do need a lab test to know whether it's Zika or something else. And the lab tests don't really give you a perfect answer every time because they have to be collected at certain times. That said, we're doing thousands and thousands of tests every week to get information to families so that they can plan.
We were talking just before coming out here, and I was asking you how many pregnant women are there on an annual basis. And you know, I have 2 children. I mean, a lot of people have gone through pregnancies. It's a very nerve-wracking time for people. And
Well,
would you think about the number of women who are going to get bitten by mosquitoes this summer and are going to be concerned, is the healthcare system and the capacity there to manage that concern?
You know, every day about 10,000 babies are born, and with Zika, if you've come back from an area that's where the virus is spreading and you're pregnant, we are recommending you see your healthcare provider, that you get a test in the first trimester and again potentially later, but that you actually understand whether you were exposed and got infected or not. But we don't yet know whether babies that are born looking healthy following a Zika infection are going to be developing normally, and so we really need to be able to follow these babies longer term. Last week we announced a new tracking system, a pregnancy registry here in the US, as well as a special one in Puerto Rico. And with those registries, we hope to be following women and their babies longer term so that we can understand and give good information to families about what to expect. You know, as you were saying, what we know about this virus is pretty concerning. You know, the microcephaly concern. These babies may never walk, talk, be able to feed themselves, care for themselves. Their families are affected for life, their siblings, their communities. We really want to prevent that kind of problem for families, but we need to know more in order to be able to prevent it well.
And Dr. Fauci, where does things stand in terms of a vaccine that would be able to sort of really put this crisis behind us? It seems like if we could get people vaccinated.
Yeah. Well, certainly a vaccine will be important in the long-term solution of how we address Zika, particularly if you have endemicity, where you have a low level of infection in a nation like Brazil. We'll say you'd really want to do with Zika what we have done with rubella. Some people may remember that in the 1960s, there was a considerable risk. About 20,000 rubella babies, congenital rubella syndrome, were born in the United States, and the rubella vaccine, which we all take as children as one of the mandatory vaccines, was really originally directed to women of childbearing age. And the way you get women of childbearing age is you vaccinate everybody when they're children so that they wind up being protected. Well, with regard to Zika, there's some good news and there's some realistic, sobering news. The good news is that we have made successful vaccines against other flaviviruses. Zika is a flavivirus. Other flaviviruses that you may be familiar with are yellow fever, dengue, West Nile. And so we have a very, very good vaccine against yellow fever, and we have a fairly good one against dengue, and we're working on an even better one. So conceptually, I don't see any scientific roadblock to developing a vaccine for Zika. And in that regard, as soon as the CDC and the NIH realized that we were going to have to put a full court press on this, we started working on a Zika vaccine. We've done it with the kinds of technologies that we've made other successful vaccines. And the way the timetable is now, we have a list of about 4 or 5 vaccines that are at different levels of when we can move them from preclinical into what we call phase 1 study to see first if they're safe. Because the big thing about vaccines that people need to realize, that even though everyone wants a vaccine, the most important thing is safety, because you're giving it to hundreds of thousands of normal people. So we have several candidates. The first one in the queue may not necessarily be ultimately the best one, but the first one in the queue is going to go into a phase 1 clinical trial for safety, and if it induces the kind of response you would predict would be protective. That's going to happen almost certainly by September of 2016. There'll be about 80 people because it's a small number of people because it's safety. We'll do it here in the United States at multiple sites, including at the NIH Clinical Center in Bethesda. We should know by the end of 2016, beginning of 2017, whether it's safe and induces an appropriate immune response. If that's the case, which I have no reason to assume it won't be, then we'll start what's called a phase 2B large multi-thousand patient trial to determine if it works. Now, the thing that confuses people about timetable, because like you, Jason, I always get asked the timetable.
Yeah.
We know when it's going to start. We know when we'll get that early data. How soon you get efficacy data depends on two factors. One, how inherently effective it is. The more effective a vaccine, the quicker you know it works. The second important factor is how many infections there are in the community at any given time. If there's still as many infections in the first quarter of 2017 as we're seeing now in Brazil, Colombia, and Puerto Rico, we could know if the vaccine works by the end of 2017, the beginning of 2018. If the infections go down, which is good news for the public health, it may take a couple of years longer. That's what happened with us with Ebola. We had a pretty good vaccine, and as the CDC and the NIH, they did it in Sierra Leone, we did it in Liberia. As soon as we got the vaccine going, all of the infections kind of disappeared.
Right.
So we kind of feel it's a good vaccine, but we haven't definitively proven it yet.
And this is a concern with this. I mean, if you look at the Yap Island outbreak, you look at the French Polynesia outbreak, even in Cape Verde, they say they think that outbreak has peaks at the moment. It's quite possible that we won't have a vaccine until after we've had a peak in the U.S. If history,
Right.
Is that
Well,
right?
Well, be careful when you say peak in the United States, Jason, because we don't fully expect. We're going to be prepared for everything.
Yeah.
But we have travel-related cases in the continental United States over 500. We have 800 plus more in Puerto Rico and in the territories. We almost certainly are going to see local transmitted. So we need to get ready for what the public and press response is that going to be. And a local transmitted will be where someone never leaves the continental United States and gets infected. We know fairly certain we'll see it because we saw it with dengue in Florida and in Texas, and we saw it with chikungunya in Florida. The critical issue is how to prevent that from becoming sustained and disseminated. I believe if we do the kinds of things that Ann was talking about public health and mosquito control, we can prevent it from being a real disseminated outbreak. But we need to be action-oriented to do that. With regard to vaccines that a population would use, I think it would likely be in those countries in which you have a degree of endemicity of Zika, that it doesn't just come and then disappear. Dengue has been in the South America and in the Caribbean for a few years now. It hasn't disappeared. Dengue is still a problem, as is chikungunya. So I don't think it's going to disappear after 1 year.
We had a story on our air this morning about people collecting mosquitoes in Houston and looking at some of the mosquito control programs there. Is there all across the U.S. places where people are collecting mosquitoes, or is it very patchy? And maybe tell us a little bit about what it's like in terms of the monitoring for Zika virus out there, especially across the southern Gulf states.
Yeah, much of mosquito control efforts are local, and so they can be, across the board in Texas from one county to another, what the capacity is. We're intensively doing mosquito surveillance and control in Puerto Rico right now, really trying to understand where are the populations and hotspots, are the mosquitoes resistant to certain insecticides, and what works in terms of reducing the amounts and the density of mosquitoes. Across the southern states, it's variable. We had a summit in Atlanta April 1st where about 30 state leadership teams came to Atlanta to talk about mosquito control. What were they doing? What could they do? Could they learn from the best practices in some of the other jurisdictions? And we know that there's a lot of room for improvement. There's some excellent programs, but across the street, it might not be as strong as where you are. And of course, the mosquitoes aren't following the district lines of where the control programs are strong. The Aedes aegypti mosquito, that's the principal one that spreads this virus, is really difficult to control. It is quite hardy. It can overwinter. Very little water is needed to maintain it. Bites during the day and the night. It's not the kind of the mosquito that you notice is biting you. It can be very subtle, and so it can be inside and outside the house. So in Puerto Rico or in some of the southern states where people leave the windows open, get that nice breeze, they can have mosquitoes inside and outside that are quite difficult to control. So this is an intense part of our work right now, really evaluating a lot of different efforts to understand what will be the best strategies.
Do you also have a strategy if you start getting local transmission, also just to deal with public reaction to that? If you start having it announced, people who have not been traveling all of a sudden are coming up with Zika in one particular place, how do you deal with that?
The implications of local transmission are quite large. You know, they're not just concern on the part of the public and particularly of pregnant women, but issues about the blood supply. You know, in Puerto Rico, we shipped blood there for about 6 weeks until we could get adequate screening tests to be able to screen the blood. So this is one of the areas where the state and local governments are really intensively trying to prepare, and again, where the resources are sorely needed. But what we really want people to do right now is when you have a travel-associated case, work that up. Go and see if there are mosquitoes around the home, because it's actually through travelers that our mosquitoes could get infected. We recommend if you're coming back from the Caribbean or the Puerto Rico, you should actually use mosquito repellent for about 3 weeks, because you might have picked up the virus silently, and if you get bit by a mosquito in your own area, that mosquito could pick up the virus. So it's not really intuitive once you're home to be pouring on the mosquito repellent. That's a message we don't know everybody's heard, but we do recommend that. In Atlanta at the airports, they actually have a loop that reminds you to do that. But we do think that one case, you should be, the health departments should be out there looking at the mosquitoes in the area. And of course, if there's more than one case, we want to understand, is it the same household? Are they nearby? So these are drills really that the states and locals need to do now as the weather gets warmer so that they can react promptly. We need to surge the lab testing. We need to get the communication out there. We need to make sure the docs know how to do the evaluations. A lot of work to do.
Do you have any sense of how likely it is if somebody goes to Recife in Brazil or goes to Puerto Rico or somewhere where it's clear that there is local transmission, how likely is it that someone has gotten infected, has gotten bitten, and doesn't know it? I mean,
well, we know that over 500 people have traveled back from Zika-affected areas to the 50 states and developed Zika infection. We probably have many more than that, because those are people that are going to see somebody and getting tested and going through the detection efforts. So we've probably had thousands and thousands of travelers. We know of over 500. I think there's issues with probability. You know, it would be great to know what the chances are, but I think the reality is one bite, and if you're pregnant, your baby could be harmed. That's just a phenomenal problem to be working on, and that really motivates us. You know, CDC has over 1,000 people who've been part of our response already, and they are, you know, actually 11 different centers in CDC are involved, because it's birth defects and mosquito experts, infectious disease folks. So the probability only gets you so far if it's your pregnancy.
you want to
Yeah, the other issue that Ann was saying, it is counterintuitive. You come back from Brazil or Puerto Rico and say, "Whew, I made it, I'm not infected, so why should I put on mosquito repellent?" The other interesting thing is that it's complicated and confounded by the fact that it's sexually transmitted also.
Yeah.
So men who return from, it's sexually transmitted to our knowledge from men to women, but not from women to men, because we've been able to demonstrate not only the presence of the virus in the semen after a person seems to have recovered, but also the documented case of sexual transmission from a man to a woman, a man to a man, but it's always man as the transmitter. That when you come back from a region, you should really take a look, and it's very well delineated in the CDC website. If you come back from a region and you have a pregnant wife, clearly you should be, if you've been infected or even highly suspected to be infected, use a condom for the duration of the pregnancy. If you don't have a known pregnant sexual partner, the same thing, that if you have been infected, you have a documented infection or high suspicion of infection, you should either refrain from sex or have safe sex with a condom for 6 months. If you're down there and you don't have any symptoms and you figure maybe I'm one of the 80% that don't have symptoms, you should use safe sex, either abstinence from sex or consistent and correct use of condom for 8 weeks. That's something that's a difficult message to get across from people. I mean, you could just see that. I go to vacation and now I'm going to come home and I have, it's not an easily acceptable recommendation, but it is a confounding issue when you think in terms of how it can be spread. It could not only be spread by someone coming back, being infected, getting bit by a mosquito, which then bites someone locally, which is a local transmission, but it could be sexual transmission.
Are we getting more information about exactly when people are at risk? I mean, is it possible that if you were infected just before you got pregnant, or if it was the very end of the third trimester, are we getting more information about?
There are larger, there are cohort studies and case control studies. The CDC is doing one. We're doing one with the National Institute of Child Health and Human Development of 10,000 pregnant women in a study that's called the Zika and Infancy and Pregnancy Study. And we're trying to answer some of the questions. Like any virally transmitted disease that results in congenital abnormality, the first trimester is always the most vulnerable with regard to deleterious effects on the fetus. But we have some concerning evidence that there has been transmission at a time beyond the first trimester, well into the second trimester and beyond, in which there has been deleterious effects. So it isn't just first trimester.
And what are you seeing?
I was just going to say, I think this is one of the most critical questions people want to know. You know, we know now that this virus can cause microcephaly and some other birth defects or problems, but we don't know how often that happens. If you have a Zika infection, what are the chances? And so these studies that NIH and CDC and collaborators around the world are doing are so important to get that information. The other kind of study that's ongoing, which we really want answers to, is about what this virus does in the body. As Tony was saying, you know, this persistent virus in semen is why we have to have these really complex guidance around sexual transmission. But you may remember from Ebola that could persist, and we've been seeing survivors of Ebola able to start a flare-up of Ebola through sexual transmission. In Ebola, it's at up to 18 months. It's been documented that there can still be virus in a survivor. We don't know what it's going to be with Zika. I mean, my goodness, what if it were the second pregnancy that you had to worry about? So I think that these are really important research questions that we need to get answers to, because the beginning of an emerging infection threat like this is where there's so much uncertainty, and it's the uncertainty that really causes concern. The more we can get knowledge and hard information, the more we can plan and understand what we need to do.
Susan, I'm wondering if at Google you're seeing people drilling down in terms of what they're searching for about Zika. Are you getting something beyond just people who are freaking out and are worried about it, or are you seeing that people are looking for specific information?
They are definitely, we're starting to see a trend where they're looking for more specific information. And again, why I'm here and why Google is so committed to this, and I should add, we spent way over $1 million with UNICEF and have given our engineers to try and help track this, right? Because what we're seeing when people start to look, they're looking deeper, they're asking more questions, and it is mirroring the epidemic. And that's the one thing that we do know a significant portion of time from Google searches is that when those questions when you take it past the first click, that you do start to see it follows a trend. Usually it precedes a trend. And so that's why we're now at the point where we're starting to shift some of those engineers to the United States so that we continue to work with the World Health Organization and with CDC and UNICEF to try and get a handle and get as much information out to people in the United States, where I think it has been sort of a late coming in terms of our concern, our knowledge. And so now, very recently, you'll see we've put up knowledge panels and directed people to places that they can go. But definitely the intensity and the click-throughs have just grown, particularly here. We can see it in the United States.
The fact that it is mosquito-borne, do you think that adds to people's concern about it, Dr. Fauci?
Well, I think it adds to a concern because it is very frustrating in how you can control mosquitoes when you have, as Ann said, a mosquito species, the Aedes aegypti, that is particularly recalcitrant to the kinds of things we do So that adds I would say, a dimension of frustration, because there isn't a lot you can do. You can try your best with larvicide, insecticide, cleaning up the environment, but even with that, history has told us that this is a real difficult mosquito to deal with. It's a different kind of public health measure than when you're trying to prevent transmission from person to person, like with a respiratory illness. It's a whole new venue of transmission, which is quite difficult to contain.
Are the insecticides working against it? Are you getting some resistance there too?
You know, this is going to be very variable. In Puerto Rico, where we have the best data, there is one insecticide that we know works from our islands testing. In some areas, there's more than one, but there's one that works throughout. But one of the issues is how to deliver it. What are the best ways? You know, inside, outside, adults, larvae. There's some innovative traps that have been developed that are being used where the mosquitoes are sort of attracted by a little bit of a sweet substance, and they end up, essentially killing the mosquitoes. So I think there's a lot of different approaches. People are naturally questioning, is it okay if it's going to kill a mosquito? What's it going to do to me? What's it going to do to my child? And so there are procedures to make sure that the products that are being used in and around homes are going to be ones that are where that safety or the benefit to risk ratio is really going to be on the benefit side. But it's an area where understanding the full range of options and investing in some innovation is very important. You probably heard about some of these innovative strategies for mosquito control, the genetically modified mosquitoes, the Wolbachia bacteria. I think it's exciting to have several new avenues being evaluated, but in the meantime, before they're really ready for massive scale up, we have to use the tools that have been out there, but we really have to assess whether they're working in real time.
Given that so many of the cases that we're dealing with in the U.S. are travel related, I have to ask the travel question. Everyone wants to know, if I'm going to go somewhere, can I protect myself? Is it possible for me to go to, say, the Olympics in Brazil and protect myself and come back and be fine?
Of course you can. Nothing is 100%, and those are the recommendations we make. First of all, to reconfirm what we've been saying, if you're pregnant, might be pregnant, going to be pregnant, don't go to an area in which there's local outbreak. That's for sure. If you do go, you can do things to protect yourself to the best. For example, wearing clothes that cover a considerable part of your body. There seems to be in some situations, reluctance to use insect repellents. The approved insect repellents that contain 30% DEET are safe. They're safe to use, so you shouldn't hesitate to use insect repellent. Now, obviously, when you're in a country that doesn't have, particularly you mentioned Recife and Maceió and places like that, they don't have a lot of screens, there's not a lot of air conditioning. Sometimes it's difficult to protect yourself in that regard. It's easier here in the continental United States because we do have that. We do have air conditioning, we do have screens. But proper dressing, keeping in a place that is not mosquito friendly, mosquitoes don't like air conditioned rooms, and using insect repellent is one of the ways that you can actually help to protect yourself.
I'd love to open it up to questions from the room. If anyone has a question, I'll start with you in the back, but wait till you get the microphone. Tell us who you are, and just wait till you get the mic.
Thank you so much for your expertise. I'm a scholar and senior associate with the Wilson Center within the Science and Tech Innovation Program. So we've been looking at this issue for some time now. The way you have framed this problem seems to be really about uncertainty management and knowledge translation from expertise and from elites to the citizenry. So I wanted to ask you if the US will consider two strategies that have been used in other regions, in Europe and in Latin America. One is the use of genetically modified mosquitoes that has been used in Brazil and in other places. And then also, could we harness the power of the citizenry, of citizens? Could we teach them? Could we harness their power to better, to improve the monitoring of mosquito populations, and also to distribute diagnostic tests? Can we think about, going further, using citizen science, using the power of citizens that understand better what this problem is about to actually innovate and
Yeah, Ann. why don't
Yeah,
you take-
maybe I can start. I think that the issue with the genetically modified mosquitoes, there are some evaluations, being considered. So the FDA has okayed a pilot assessment, but with community input, and so the communities are considering whether they want to go that route or not. In terms of the citizen engagement, incredibly important. This is an area where everybody has a role to play. I don't know that I would say for diagnostic test distribution. I think, at least in the US, we have a pretty good diagnostic test distribution system. But I think in terms of source control, in terms of making sure that you've cleaned up the neighborhood, cleaned up the backyard, got rid of the standing water and the tires and so forth, or cleaned up the garbage areas, but also in terms of the information. And so that issue of pregnant women making sure they know what they need to do to protect themselves, or the couples know what they need to do. So I do think that that question of mosquito monitoring, there are probably some innovative ways they could be tapped into that. There's certainly a science to figuring out which kind of mosquito it is and is it resistant or not. But I think there's more power of communities that could be used. That is part of what is being developed for Puerto Rico, and I think in the southern states that is a good idea as well.
I wonder, Susan, is there some way to get people to move beyond just searching, and I don't know whether there's some way to take that interest that's there and channel people to take action the way she was asking.
Well, I think that when I was thinking about that, I was thinking about a proposal while you were speaking,
Yeah.
particularly for here in the United States. I think one of the things we've done pretty successfully in Latin America is using our YouTube channels and partners, right? Because then you really have an ability to deal with their subscribers, and it's not just a one-shot message, and you're reaching so many different populations that we work with UNICEF and the World Health Organization in terms of how to get that message out there. The knowledge panels are written, particularly here in the United States, with the help of our health partners, because that's not what we do. And so whenever we get the opportunity to get a message from these amazing individuals, we will put it on our health panels. And so as we were here, I was just thinking about the memo that I'm going to send to Mountain View. This is why Jane invites me here, because she knows I just
Get your brain going.
it's not what I say, it's what I do after I leave. To talk about some more proactive things that people can do in the United States in particular, and maybe involving some more less traditional media outlets to get some of this conversation going.
Yeah, just to add, one of the things that would help in areas where there's a lot of circulation, like Puerto Rico, is installing screens. So all of the schools or all of the clinics that need these screens, when we start to do the math and figure out what's that going to take, it's a humongous effort. But community volunteer and engagement may help. There are some private sector companies sort of helping think through the product availability, and there's other involvement of governments. But I do think there's some community efforts of, you want to clean up a park one day, well, maybe you can also help with screen or nets availability in some of the public settings.
I want to get to a few more questions, like all the way in the back corner over there. Tell us your name as well.
Hello, my name is Jorge Benavides. I'm a physician in tropical diseases, but now a PhD student in anthropology.
Go ahead and stand up. We're not quite hearing you. There we go.
Hello.
Yeah.
Hey, my name is Jorge Benavides. I'm a physician, tropical diseases, and currently a PhD student in anthropology. So my research has to do with Zika and dengue and the cultural factors around it in Central America. So my question has to do with, since continuing with the idea of people's behavior in prevention, I wonder if there is social science research in your agencies that deals with the different cultural and structural conditions that would, condition and frame the way that people react and make decisions towards prevention of a disease.
I can say there has been some involvement of that in some of our field work, in particular really focusing on planning for the communication or outreach efforts where, we've done focus groups or key informant interviews. A lot going on with pregnant women in Puerto Rico to understand what are their concerns, what are their practices, what are they interested in. But there's probably a lot more that could be done. I'm not sure about NIH's work.
So we're not doing this ourselves and funding it, but our interactions with our colleagues in Brazil. what you said about social determinants are very important. But what we're finding is that the ability of people in a particular region to have any even control over what they of their risk is very difficult, because like in many diseases, poverty is a really bad thing. And if you live in an area where you have still water that you can't get rid of, you have environmental neglect, which leads to the breeding of mosquitoes, makes it very, very difficult. And the people who, at least in the beginning of the epidemic, that suffered the most were the people who lived in that very poor northeastern section of Brazil, in Pernambuco and in Alagoas states there, was really the epicenter early on. We're seeing it more diffuse now. And it really had nothing to do with social or behavioral issues. It had to do with the unfortunate poverty circumstances that they were in.
Can we take one down here? Yep, with the beard. Here, the mic's coming.
Thank you. Herb Rose.
We'll get to you next. I'll get you.
I have a quick question. Most of the news stories have been directed towards encephaly and the effects on pregnant women. I'm wondering whether it affects another demographic, neurological diseases that might affect other parts of the population.
You're talking about Guillain-Barre and some of those. Yeah.
Yeah,
You want to
yeah,
take that?
yeah, well, Guillain-Barre, there's no doubt now we're seeing, we don't know the exact incidence of Guillain-Barre. The paper that was published said it was 24 per 100,000 infections. That's not necessarily the most accurate number. We need to do more of these cohort studies that we follow prospectively to be able, but the relationship between Guillain-Barre and Zika infection is pretty clear. We have seen individual case reports, and we've got to be careful because we see this in almost any viral disease. There are outliers, like a case of myelitis in a 17-year-old woman, case of meningoencephalitis in an 81-year-old man, 4 cases of ADM, acute disseminated encephalomyelitis. We can't say for sure that they're a significant part of it, but there doesn't seem to be anything of any significance above and beyond Guillain-Barre in a non-pregnant situation. What we are seeing, which is important, and I think this is an underappreciated fact, that we look as microcephaly as one particular morphological problem that's the thing that's associated with infection. It goes way beyond that, because if you look at these babies, microcephaly may be one reflection of both developmental abnormality due to the virus or direct destruction of neurologically developing tissue. But these babies, as you follow them, have a variety of other issues, retinal eye problems, deafness problems, and a variety of other things. So I think when we do finally get the full scope, we're going to see that microcephaly may be just the most obvious gross manifestation of the effects, and there are a lot of other things that we'll be seeing that will be detrimental to the developing fetus.
Did you want to add something?
Yeah, just in terms of the Guillain-Barre or the neurologic complication of Zika that's in a non-pregnant setting, we've made recommendations for avoiding travel if you're pregnant, because we have enough data to say the risk is high enough, in terms of this concern about the birth defects. We don't know of factors that make it more likely somebody's going to get Guillain-Barre syndrome following a Zika infection. And based on what we know right now, we don't have information to say the risk is so high for everybody that nobody should go to these places. In general, Guillain-Barre syndrome of any cause increases with age. The older you are, the higher the risk is. But it's a pretty uncommon condition. So I do think that further study of the full spectrum of Zika infection, from the mildest, no symptoms, to what are these rare but potentially serious complications, may help us understand whether there are some predictors that would help give some warnings to people.
I wonder if Zika also is just showing us some overall weaknesses. I mean, is there the potential that another virus that's also mosquito-borne could be creating Guillain-Barre in a much higher rate than, what did you say, 24 per 100,000? I mean, is it showing us that there's the potential there in terms of the way that diseases spread, that something that could be even far worse than Zika has access
It may not necessarily be happening now, but you said something is the possibility of other infectious diseases. Yeah, they are going to keep coming. At the end of 2015, I was giving talks, and as was Ann and Tom Frieden, at the end of the Ebola epidemic, that you can be absolutely certain that we are going to see another emerging infection at some time. And no sooner did I catch my breath than Zika came. So we are going to see continual emerging and re-emerging infections. That's just the nature of the interaction between microbes and humans. I mean, sometimes you get something that is explosively transforming, like HIV/AIDS, which we never had before, and then there were over 70 million people infected. You have things that are little blips that are curiosities. You have things that come and then good public health measures suppress them, like SARS. I mean, we didn't have a vaccine for SARS, but very intensive classic public health measure suppressed them. And then you get something that's devastating to a region like Ebola, and now something that's causing concern in the Americas, but beyond the Americas, because I can tell you the Europeans and people in Africa are quite worried that this is going to be seeing what we're seeing in the Americas, we're going to see there. So Jason, you're right. There's possibility that we're going to see a lot more of this.
Yeah, I mean, between the way that we live and the way microbes evolve, there are going to always be new ones. And, you know, this one is more concerning than a lot of them because of the, you know, permanent harm that babies can experience. But we know that there are more of them. I mean, there are some circumstances that let us know this was happening. You know, a very dense population in northeastern Brazil, a good system of surveillance to detect that it wasn't just dengue or chikungunya, but it was actually Zika causing the fever that people had. And then astute clinicians recognizing, whoa, you know, I haven't even ever seen microcephaly. Now I have several in my clinic that raise the alarm about it. Yeah. But we need every country to have a strong frontline public health system where they can detect new problems, they can react quickly, they can prevent catastrophe. If we'd had a strong public health system in Guinea, Liberia, Sierra Leone, we would not have had, you know, 28,000 people suffer from that disease. Even in the US, where we have a good system, we weren't as ready as we needed to be for the importation. So between human behavior and the mosquito concern, and then these pathogens that just really adapt and evolve and spread, we know we have to be ready for multiple outbreaks at the same time.
I'm going to go to this guy right here who I was calling on last time. Yep. Just tell us your name.
Thank you, Jason. Gavin MacGregor Skinner from Hershey Medical College, Penn State University. Recently just come back from a number of countries in South America doing risk assessments for Zika at hospitals and laboratories. Now doing the same thing here in the US, both at the state and local county level. What's really evident from the people that I've talked to is that Zika's become a gender nightmare. The burden that we've put on women of reproductive age, whether they can protect themselves from mosquito bites or actually decide when and how and when they're going to have sex, is really, they're not empowered to do that. We've seen a lot of worried well in the countries I went to, but also now here in US states, where the worried well are turning up to the physician and the hospitals going, I'm pregnant, do I have Zika? We're talking to a lot of physicians and nurses about the counselling and mental health needs for the families, the grandparents, the community. And I put the analogy to other programs that we're familiar with, like malaria, national campaigns, we've gone to schools. Is it time for a US national Zika, a United States national Zika campaign, so that we do mobilise the community and we do address the needs and we take that burden off just the mums?
You know, we do think that everyone has a role to play, and I know that pregnant women have so many things. You know, we're telling them don't do this and do that, and, you know, often they can feel like they're in this alone. But I think the idea of protecting our communities against the harm that Zika can cause is very important. But we have to remember that the risk is really different, you know, in Minnesota than the Florida Keys than Puerto Rico. And so right now we are launching a communication campaign in Puerto Rico to really make it a whole community issue with billboards and bus signs and, you know, the full works, partly funded through the Gates Foundation because we don't have a lot of money yet. But I think the issue of this is not any one individual's problem, it's all of our problem. We need to work together, and we need to not put even more pressure on one person. The other thing to say is that in Puerto Rico, 2 out of 3 pregnancies aren't planned. In the US, one out of 2 isn't planned. And if you're not planning to have a pregnancy, you know, having access to safe and effective contraception is a good thing, because this is a time where, you know, having that access would be important if you're not trying to get pregnant, since there's a new threat to pregnancies that you have to be concerned about.
You know, actually, speaking about this issue of like, it not being as much of a threat in Minnesota, is there more clarity on the transmissibility versus of Aedes aegypti versus albopictus? Because the way that those two mosquitoes, if you look at the map of them, it's very different. So do people all up the eastern seaboard need to be worried about this? Is there more clarity on that? I mean, is it mainly Aedes aegypti that we need to be worried about?
It is. I mean, it can be transmitted by albopictus, but in situations in which you've had overlap between albopictus and Aedes aegypti is clearly the dominant vector for this disease for a number of reasons, not least important of which is that Aedes aegypti focuses on one species, the human. Other mosquitoes get distracted. They bite animals. We dilute it out. But the Aedes aegypti has one objective: bite humans and only humans. Indoor, outdoor, morning, noon, night. So whenever there's a competition, Aedes aegypti is going to be the mosquito you got to worry about.
Another one. Take a woman down here.
Hi, my name is Erin Kenny. I'm from the Glover Park Group, and recognizing that I'm speaking to public health professionals and business representatives, I'm curious if you could reflect on the media landscape associated with Zika and public health threats that are popping up in the past generally. How can we learn from the domestic media frenzy related to Ebola? And how does increased attention to public health threats help or hurt domestic and international response, raising the political profile of health threats, helping or hurting? If you could just speak on that.
Susan, do you want to try and tackle that one?
No.
No?
I mean, I think, you know, we have the comfort at Google, at least, of where people have to come seek us, right? And so I think probably what we're talking about here is not causing panic in areas where there need not be panic. Certainly I was pregnant twice and, you know, went through anxiety every day for everything that I caught or did or damaged, you know, I mean, and so to make sure that we don't, that we arm people with knowledge but not produce undue panic, and make sure, and I think that's one of the things where Google is helpful, because people who do have concerns will be brought to a series of levels, particularly now in the United States with these knowledge panels that are going to be updated all the time. So those people who are concerned, who may be at risk, are going to be getting the information at the same time, working with these individuals so that when we start to see mappings that mean that we and the rest of the media have to be more aggressive, you know, we can see those trends.
Yeah. I think the media has been pretty good about not being overly hysterical at all about this. In fact, I think they've been really, I've been pleased with it. And so I don't see, I mean, there's always exceptions, but for the most part, there haven't been stories or headlines that have been egregiously misleading about threats that aren't there. Usually, I mean, there was a situation, and it was really, you know, isolated during the Ebola outbreak, when there was this paper that came out that said that Ebola is an RNA virus that's mutating, and the next thing you knew, somebody who shouldn't have said it came out and said, mutating, it could be respiratory borne.
Oh,
the
I
next thing
remember
you knew, that there's this concern that now all of a sudden Ebola is going to be respiratory borne. I didn't like that. I thought that was a little bit over the edge there, talking about that when there was no evidence whatsoever. But I wouldn't blame that on the media, but that's something that came out in the media that was, I think, misleading.
Yeah.
But that's really the challenge, though, right? I'm sorry, it's informing and not alarming.
Right, exactly.
Yeah, I think, you know, I do agree that I think the media's been responsible, and, you know, frankly, this virus is scary enough on its own. You know, you don't actually have to hype this to have a virus that a mosquito bite can infect you, and you can have a baby that's harmed forever. But I actually think we have another problem, that we just get fatigued with the new problem. And you know, Tony and I will be working on something for years, but the public moved on years ago. And we can't fix this overnight. This is going to take time and a lot of work. And so whether it's the media or some of the social media, the attention to it can't fade before our response is strong. And we really need to not hype this, but find a way to have persistent attention and focus. And in public health and in research, you know, we're really activated. We're working very intensely. But how we get the public support for that is without alarming people is, I think, a challenge.
We have time for a few more questions. Let's take someone way in the back on the right there. Again, tell us your name, please.
Hi, my name's Cheryl Silverbrook. I'm an OBGYN at the George Washington University, and it's going to be a long summer for us with every woman coming in with a mosquito bite. Is there just general advice you have for that? I appreciate it.
Oh, boy. Yeah, thank you so much for what you do. You know, I know in OBGYN, you're always counseling because, you know, people want to take care of themselves. They want a healthy baby. And, you know, there's probably many other things besides the insect repellent that are important for women to do during their pregnancy. But I think we hope to have better and better information that can help put the risk in context. Right now, we don't have any local transmission in the 50 states. The only part of the United States with local transmission for mosquitoes is the Puerto Rico, U.S. Virgin Islands, American Samoa, the territories. So really right now the focus is travel risk and having that health department come out and assess the travel associated circumstances. But good luck with the summer and the women that you'll be seeing.
Yeah. What's going to happen is that women, the first message you give to your patients is that if there's no local outbreak, there's very little chance that a mosquito bite that person got in their backyard in Bethesda is going to get them Zika. I mean, that you never say zero, but it's almost zero. If we do have a local outbreak, which as I mentioned just a few minutes ago, I think there's a reasonably good chance we'll see it likely on the Gulf Coast, the way we did with dengue and with chikungunya, then it's not going to be unreasonable for someone to come into your clinic at GW and say, I was sitting in my backyard and I got bit by a mosquito, and I know that there's Zika in Florida and in Texas, so how do I know that that mosquito? That's going to be a problem because they're going to be demanding to have a test for Zika. And when you have a demand for tests, there's two types of tests. There's a test, am I infected now? A PCR test that will tell you whether you're actively infected. And then there's one that if you got infected 3 weeks ago, the question is, was I infected? And that's the test that we're working on to get a great deal of specificity to make sure you don't confuse it with something else, like having been vaccinated with yellow fever, or if you happen to live in the southern part of this region to have had dengue. So that's going to be a challenge, and that's the reason why the CDC, to a great extent, and NIH to some extent, we're working on getting diagnostic that's highly specific and highly sensitive to be able to answer the question of somebody, was I infected 4 weeks ago because I'm 8 weeks pregnant now? That's the question.
I mean, when you look at the idea of are we prepared as a nation for this, we were talking earlier, and what was the number of tests you said you could do a week on PCRs? 23,000?
Yeah, well, that's what we're doing right now, 23.
Right, and
we have capacity for that, but we
potentially millions of women who are
right.
pregnant.
Well, one of the things we have a couple tests that the FDA has given emergency use approval for, and there are two companies that have also recently gotten approvals, I believe. And I think we really want the commercial sector to step up with this, and that's another reason why I think the resources are quite important, that if they see this as a real commitment, there's going to be more commercial interest in doing their part. But yeah, we're going to have, ideally we get better tests, and ideally we can scale even further with the tests that we have right now.
And I don't mean to play up the doomsday scenario, but of that scenario you were just laying out, if you do start having local transmission, it's not just the woman who was bit. She's like, my husband works as a roofer over there, and now do I need to be concerned about whether or not there's sexual transmission? So I do think that if we start to get local transmission, a lot of this some of that will really ramp up in terms of the concern. And how that gets managed, I think, is going to be really the hallmark of how we
Right.
deal with
Yeah,
this.
and you know, it's very interesting because we have faced this with other perceptions of risk. You know, with the anthrax letters, people were asking me whether I actually picked up the letters that came into my house. Remember,
Oh,
some
I
of you
used to
may
keep
not
it in the
remember.
garage.
Oh, yeah, and a variety of things in the early years of HIV/AIDS, of whether or not you could get it by casual contact. So the issue of relative risk. So a risk may be a new risk, namely the risk that your patients perceive that they have. That risk may be far, far less than the risks that they accept every day of their lives, but they're risks that they're used to. New risks, even though they're much less risky than a risk of getting on the beltway every morning, which is probably more risky than anything that your patients face, there's the extra twist with this. When the risk is to your developing baby, that trumps everything.
Absolutely.
That's really the thing that's going to transform people's perceptions of risk, because that brings it into a whole new category.
Totally, well said.
Yeah.
Well said.
Jane, I think we have time for about one more question. Why don't we go to you?
Well, so what a superb panel, first of all. I mean, exceptional people who know how to tell it straight and not scare us to death. Although, as a grandmother, now I'm scared for the yet unborn pregnant, new grandchildren my children will have. But my question is about Congress. I started there. Susan, I know you want to answer this question. Do we need these bills that have been passed by by both houses? Do we need Congress to step in? What do we need from Congress, and how do we make that happen in this toxic, partisan town?
Well, I guess my initial reaction would be that even though this town is extremely partisan, one would hope that an issue like this would certainly not be partisan. Doctor, when you were talking about the difference in this, which really is that emotional and societal difference of taking responsibility for something and making decisions to deal with your unborn baby or your child is something that I don't know that we've, at least in my lifetime, experienced with regard to the level of concern and the generations after, the repercussions for generations after. And so it is saddening that this is one area that, because what I've heard you say the entire time is this is a significant matter of resources to get it done well and thoughtfully.
But Jane, the answer to your question is that the president asked for $1.9 billion because we need $1.9 billion.
Yeah.
He didn't ask for it for slush fund. We need it. So what the CDC is doing, what we're doing, what other agencies are doing, is we are now using money that we would otherwise be using for other things. You could only do that for a certain period of time, and you can't go beyond that. Then you got to start paying it back, and then you're going to stop doing things that are also very important. So we really need the Congress to act quickly. And taking money from the Ebola account is not the solution. It's just not, because as Ann said, we're still seeing this outbreaks of Zika that if we lay our guard down, the CDC is doing how many a week? Thousands of tests?
10,000 a month.
A month. I
Yeah.
mean, we can't stop doing that otherwise. So, but the short answer, we need the money the president asked for.
Seems like it would be a safe political vote, too, you think?
I think that's a fairly good place to end. Bring it right back to where you started. Well, thank you all for coming, and thank you all for being here.
Thank you.